Welcome to the second lecture of this second week of our Research Methods Bootcamp. We shall be considering randomization and blinding in this lecture. This lecture covers the fundamental principles and methods of randomization and blinding in clinical trials. Randomization is crucial for eliminating selection bias, for balancing known and unknown prognostic factors, and also to ensure the validity of statistical tests. In this lecture, we'll consider key randomization methods, which include simple, block, stratified randomization. In this lecture, we will also stress that an independent third party should prepare the allocation schedule. We'll define different blinding techniques, which include unblinded, single blind, double blind, and triple blind, and explain how each level protects against various sources of bias in trial conduct and assessment. Randomization is a process by which each participant has the same chance of being assigned to either intervention or control. For example, if you consider that we allocate participants to either intervention or some other control group using the toss of a coin. If the coin is a fair coin, then the participant has a 50% chance of belonging to the intervention group. So we can say that there's a 50-50 chance of the participant being assigned to the intervention group. And so we're able to tell the probability with which the participant will be assigned to either of the groups. And this is a key feature of randomization, in that regardless of how complex the randomization strategy is, the element of chance underlies the allocation process, and we can say what the probability is of the individual being assigned to a particular group. However, the key thing here is neither the trial participant nor the investigator should know what the assignment will be before the participant's decision to enter the study. Experimental bias could either be selection bias or accidental bias. If it's selection bias, then the allocation process is predictable. That is, the decision to enter a participant into a trial may be influenced by the anticipated treatment assignment. So if, for example, we have a clinical trial of a new drug that potentially has better outcomes than existing drugs, then it's very possible that the investigator may be tempted to assign a participant to whom he or she is empathetic or sympathetic to into the drug treatment arm, because he hopes or believes that the person may benefit from that treatment. So that's an example of selection bias. Accidental bias arises when allocation to treatment groups does not achieve balance on risk factors or prognostic covariates. Randomization tends to produce study groups that are comparable with respect to known as well as unknown risk factors. And randomization removes investigator bias in the allocation of participants and guarantees that statistical tests will have valid false positive error rates. So why do we randomize participants? One of the first or key reasons is to eliminate selection bias. And so randomization guarantees an unbiased treatment assignment by taking the assignment decision out of the hands of the investigator. Treatments are selected for participants independent of other prognostic factors, and by so doing, we eliminate selection bias. Randomization also helps us to reduce accidental bias. It does not absolutely eliminate it, however. Randomization helps to ensure that balance of known and unknown risk factors or prognostic covariates between treatment groups are averaged out, such that no treatment has an unfair advantage. Randomization also helps to assure the validity of statistical tests that we use. It does this by ensuring that the confounders are absent or balanced across the groups, and also ensures that there is independence of the groups that are being compared. So how do we get random numbers that we use to randomize? We could use a random number table, which is a list of random digits consisting of a list of digits constructed by a process designed to satisfy the following two conditions. In any predetermined geographic position in the table, any one of the 10 digits 0 through 9 has a probability 1 out of 10 of occurring. So there is an equal probability of the digits 0 to 9 occurring in that location. The occurrence of any specific digit in any predetermined geographic position in the table is independent of the occurrence of specific digits in other positions in the table. And so there is independence of these digits. We could also get random numbers through random number generators and many statistical packages, including SAS, SAS, Stata, R, SPSS, Excel, and so on, can be used to generate a large number of random numbers, and this is based on the uniform distribution. The general rules to follow are these. Assignment is unknown to all persons until needed for treatment initiation. Future assignments cannot be predicted, and assignment probabilities are predetermined. The allocation sequence is reproducible. Thus, a departure from the assigned allocation sequence can be detected when monitoring the randomized clinical trial or when carrying out audits. What randomization methods do we have? We have what are known as fixed allocation randomization methods, and we have the adaptive randomization methods. In the fixed allocation randomization methods, fixed allocation procedures assign the interventions to participants with a pre-specified probability that it usually is equal, and that allocation probability is not altered as the study progresses. And we have three types of fixed allocation randomization. We have simple, block, and stratified. In simple randomization, we leave to chance the balancing of treatment A and treatment B. That is to say, it is completely random. And we could either use a random number table or we could use a random number generator. Simple randomization has the advantages that it is easy to implement and it satisfies all criteria for randomization. The disadvantage, however, is that at any point in the randomization, including at the end of the process, there could be substantial imbalance between the groups. And when we say imbalance, what do we mean? We mean that participants may be unequally assigned to the groups. And how likely are these imbalances to occur? If, for example, we have 20 participants that are randomized with equal probability to two treatment groups, the chance of having a 12 to 8 split, that is to say 60% of the participants are in group A and 40% of the participants are in group B, or even a worse, is approximately 50%. So, this is something that can happen with small sample sizes. For 100 participants, the chance of that same ratio is only about 5%. Thus, we see that the larger the sample size is, the less likely that we are to have imbalances occurring. In block randomization, the subjects are divided into blocks according to chronological time in which they enter the study and are randomly assigned to treatment A or treatment B such that there is balanced allocation between treatments within each block. Blocking is therefore a restriction on the randomization over time. And so this graphic illustrates that concept. And so what happens is that the size of each group is similar over the entire course of the study. So for example, if you consider that there are 6 individuals in block 1, these 6 individuals are randomly assigned to intervention and control, such that at the end of block 1, we have 3 people in the intervention group and 3 people in the control group. And so what this does is that over time it assures that the groups are not imbalanced, but have equal sizes. What are the advantages? Again, as we have discussed, it assures equal numbers of participants are recruited to each treatment group throughout the recruitment period. It also controls for chance imbalances between treatment groups on important patient characteristics, which may change during the course of recruitment, especially for trials that have a long recruitment period. For example, patients from different hospitals, different doctors treating, and so on. The disadvantage of block randomization that it can be easier to predict future assignments. We can mitigate this by not stating the block size in the protocol. It also imposes more work to implement a block design, and this depends on how complicated the blocking becomes. For example, we have 20 subjects and we have 2 treatments A and B. The first decision therefore would be, how big are the blocks to be? So for example, if we have blocks of size 4, that is to say 4 subjects per block, we're going to need 5 blocks. Each block would have 4 subjects, 2 assigned to A and 2 assigned to B. After 4 subjects have been randomized, there will be 2 subjects in group A and 2 subjects in group B. After each block, there will be equal numbers on A and B up to that point. So what are the possible block combinations? If we start with 2 A's and 2 B's, the question is, how can these 4 people be ordered? So if you look at that box here, it shows the 6 possible combinations or permutations of 2 A's and 2 B's. And these are all the possible permuted blocks of size 4. So if we're considering blocks of size 4, it means we're going to have 6 possible permutations. Stratified randomization. In stratified randomization, separate randomization is performed for separate strata that are defined using baseline characteristics. This ensures that the randomized groups are not imbalanced on the stratification variable, and it helps to reduce or eliminate variation in the outcome measure due to stratification variables. It allows for statistical analysis to account for variation in the outcome measures among strata, and stratified randomization permits valid subgroup analysis. For any single study, especially a small study, there is no guarantee that all baseline characteristics will be similar in the 2 groups. Stratified randomization requires that the prognostic factors be measured either before or at the time of randomization. If a single factor is used, it is divided into 2 or more subgroups or strata. If several factors are used, a stratum is formed by selecting one subgroup from each of them. The total number of strata is the product of the number of subgroups in each factor. The stratified randomization process involves measuring the level of the selected factors for a participant, determining to which stratum she belongs, and performing the randomization within that stratum. So what factors do we stratify on? We stratify on baseline factors that are strongly associated with the outcome. In a multi-center study, we almost always stratify on the center. So subjects from different centers may have different baseline characteristics. The standard of treatment may vary from center to center, and each center represents a replicate of overall trial. Stratifying variables should be easily observed, measured prior to randomization, and relatively free of measurement error. Suppose an investigator wants to stratify on age, sex, and smoking history. If we were to look at the various groups within each of these variables, for example, in age we have 3 levels, for gender we have 2 levels, and for smoking history we have 3 levels. Thus, the design is going to have 18 strata, and we arrive at that by multiplying the different levels. So 3 times 2 times 3 gives us 18. In each stratum, the randomization process itself could be simple randomization. In practice, most clinical trials use some block randomization strategy. Under a simple randomization process, imbalances in the number in each group within the stratum could easily happen, and this would defeat the purpose of the stratification. Consider this example. And so, in strata 1, using block randomization, you could have that sequence as shown, and so on and so forth. So this is just an example. What are the advantages? Stratified randomization may prevent bias from chance imbalance between treatment groups on an important baseline prognostic factor. It will increase the precision of the treatment comparisons made, and so it increases power. It will facilitate within stratum subgroup analysis since the treatments will be balanced. If important prognostic factors are balanced, then the study will be subject to less criticism. It is more difficult to implement and therefore can be more prone to error. If quotas are requiring a minimum number per stratum, recruitment in some cells may be difficult. Adaptive randomization. Adaptive procedures change the allocation probabilities as the study progresses. And so this is the contrast with the fixed allocation methods, where the probability does not change as the study progresses. In adaptive randomization, this probability changes as the study progresses. And there are several methods. So we have the baseline adaptive randomization, and we have the response adaptive randomization. And under each of these broad groups, we have subgroups. So under the baseline adaptive randomization, you have biased coin randomization, undesign minimization. And under the response adaptive randomization, you have play the winner and 2 unblinded. All these are beyond the scope of our syllabus. So who prepares the randomization schedule? It should not be prepared by the investigators or clinical staff. A third party that is not associated with the day-to-day operations of the trial prepares the randomization. The investigators and clinical staff should not have the knowledge of the assignment order. Once the assignment order is determined, it should not be changed by the investigators. And this brings us to blinding. A clinical trial should ideally have a double-blind design in order to avoid potential problems of bias during data collection and assessment. In studies where such a design is impossible, other measures to reduce potential bias are advocated. What types do we have? We have the unblinded trial, single blind, double blind, and triple blind. In an unblinded or open trial, both participant and investigator know to which intervention the participant has been assigned. This is simpler to execute than the other types, and it more accurately reflects clinical practice. The main disadvantage of an unblinded trial is the possibility of bias. The participant may report symptoms and side effects and prescription of concomitant or compensatory treatment. All these are susceptible to bias. Examples of unblinded trials are comparison of surgical procedures and medical devices. Also, changes in lifestyle. Also, learning techniques. These are all examples of trials that cannot be blinded. In a single blind study, the investigator is aware of which intervention each participant is receiving. Participant, however, is unaware. This is often simpler to carry out than a double-blind design. The disadvantages are similar to those for unblinded design. Both unblinded and single-blind trials are vulnerable to bias by the investigators, and this relates to group differences in compensatory and concomitant treatment. Investigators may feel that the control group is not being given the same opportunity as the intervention group, and as a result may prescribe additional treatment as compensation. Concomitant treatment means any non-study therapy administered to participants during a trial. In a double-blind study, neither the participants nor the investigators responsible for following the participants, collecting data, and assessing outcomes should know the identity of the intervention assignment. The risk of bias is reduced. The preconceived ideas of the investigator will be less important because he or she will not know which intervention a particular participant receives. The disadvantages are that it does not protect against imbalances in concomitant medications. Also, duties or functions which could be accomplished by the investigators must now be taken over by others in order to maintain the blindness. In a triple-blind study, the committee monitoring the response variables is not told the identity of the groups. The committee is simply giving data for the groups, and this is an extension of the double-blind design. A triple-blind study has the theoretical advantage of allowing the monitoring committee to evaluate the response variable results more objectively. This assumes that appraisal of efficacy and harm, as well as requests for special analysis, may be biased if group identity is known.